Hello to you all guys and welcome back to my channel. My name is Tommy, I am a human nutrition student and researcher at the university. What I do in this type of videos is to synthesize my classes so then I can explain and teach you the best and most valuable information you need to know. Today we're going to continue the pharmacology series of videos and we're going to take a look at the drugs related to the genitourinary system. So let's begin. Interactions in pathologies of the genitourinary system. Kidney functions. Elimination of many of the body's waste products, maintaining a constant and normal internal environment, having to do with heat, absorption of water, water elimination and pH balance, and also the synthesis of various important substances such as renin, erythropoietin and vitamin D3. This is the nephron, the part of the kidneys where we have in the corpuscle we have the filtration. In the proximal tubule we have the secretion of urea and the reabsorption of organic compounds, glucose, ions, water and amino acids. In the loop of Henle, the descending limb, there is water reabsorption. And in the ascending limb, there is no water, but we reabsorb sodium and chlorine. In the distal convoluted tubule, we have a secretion of potassium and protons, and a reabsorption of water, calcium, sodium and chlorine. And in the collecting duct, we have a reabsorption of water, calcium, sodium and chlorine. As you can see here, there are already some interactions with the medications. Aldosterone, ADH, aldosterone, furosemide, thiazides, dopamine. Anyway, we have to differentiate between the principal cells that reabsorb the sodium and secrete the potassium using the sodium-potassium pump, and the intercalary cells that secrete the hydrogen ions, the protons. There is the presence of aquaporins for the water reabsorption in the collecting duct here to facilitate it. And there is also this thing, the renin-angiotensin aldosterone system, which is involved indeed in the excretion and secretion and reabsorption of water and minerals. So what are the type of drugs we have here? Diuretics first. They are used for lowering the sodium reabsorption and increasing the water excretion. They are prescribed for high blood pressure and edemas. Types. We have the loop diuretics, distal tube diuretics and potassium-sparing diuretics. The loop diuretics are the furosemide, bumetanide and toracemide. The sodium excretion is between 15 and 25%. They act in the thick ascending portion. They will inhibit the co-transporter of sodium, potassium and chlorine. As you can see here, there is the furosemide acting in the ascending limb of the loop of Henle. What they do is to increase the sodium in the collecting duct, and therefore there will be a higher secretion of potassium and protons. This will create a metabolic alkalosis because we are getting rid of the acidity from the protons. There is also an inhibition of calcium and magnesium reabsorption and a vasodilation. They are not prescribed in severe renal failure. Food and ginseng may reduce the effect of the furosemide, and licorice has an antagonist effect because licorice tends to do the reverse. There is sodium and water retention and potassium excretion when these drugs are taken with licorice. And indeed, the loop diuretics, they create hypokalemia, hyponatremia, hypotension, hypovolemia, and metabolic alkalosis. The distal tube diuretics are the thiazides, the hydrochlorothiazide, and the sulfonamides, the chlorthalidone and the indapamide. They have a sodium excretion of 5 to 10%, so a little bit less than the loop diuretics. They inhibit the sodium-chlorine co-transporter, increasing the secretion of potassium and protons in the collecting duct. Again, the same thing, but in another part of the nephron. They decrease the calcium excretion though, and their maximum effect is 4 to 6 hours after taking them. They are not prescribed in hypokalemia, hyponatremia and hypercalcemia because they worsen the situation. And be careful in diabetes mellitus because thiazides cause hypoglycemia. They are better tolerated than loop diuretics, but still high frequency of urination. There is an interaction with licorice due to an antagonistic effect, the same as here, and they also produce hypokalemia, hyponatremia, hypotension, hypovolemia and metabolic alkalosis. Now let's take a look at potassium-sparing diuretics. Here we have the sodium channel inhibitors, the amiloride and triamterene, and the aldosterone antagonists, spironolactone and splerenone. They have a sodium excretion of 2 to 3%, so as you can see, it's getting lower. They act in the end portion of the distal tubule and in the collecting duct, so right at the end. And because of this, there is a difference. The sodium channel inhibitors, they block the reabsorption of sodium, but they lower the secretion of potassium and protons. Why? Because if there is no sodium to interchange with the potassium will not come out. And if the potassium doesn't come out, the protons will not follow it. In the aldosterone antagonists, there is no aldosterone, so they inhibit it. And therefore, there is a lower sodium reabsorption and lower potassium and protons secretion. Again, this is because here, in the loop diuretics, they inhibit the reabsorption of sodium here, so it starts to build up a lot through the distal tubule and the collecting duct. Therefore, it increases the secretion of potassium and protons. But as we are getting towards the end of the distal tubule and in the collecting duct, we're not going to build up sodium. Therefore, here we don't have sodium enough to interchange with the potassium, and therefore the potassium will not come out and the protons will not follow the potassium out. And this is why we are accumulating potassium, because of the position in where we inhibit the sodium reabsorption. They are prescribed in heart failure and hyperaldosteronism. They are not prescribed with the angiotensin converting enzyme inhibitors because they create hyperkalemia, and they're not in renal failure. They can cause digestive problems as well as hyperkalemia and hyponatremia. And in the aldosterone antagonists, there is also the gynecomastia, menstrual disorders, and male sexual dysfunction that can happen. And they have an interaction with potassium-rich foods, of course, and there is a risk of hyperkalemia. As a general rule, the prolonged treatment with diuretics will create hypokalemia, not in the potassium-sparing diuretics though. And the hypokalemia will increase the toxicity of other drugs. Now let's talk about urinary incontinence. It is the involuntary urine leakage. And this has to do with the parasympathetic nervous system that innervates the bladder. It controls the contractility. Types of incontinence: we have the motor type, inability to inhibit the contraction in the filling phase, overstimulation of sensory afferent pathways of the bladder due to overactive musculature or due to prostate problems and neurological lesions. Here we have two types of drugs. The muscarinic receptor antagonists. We have the oxybutynin, solifenacin, tolterodine and fesoterodine. And on the other hand, the urinary antispasmodic, the mirabegron. The oxybutynin will relax the detrusor muscle. They are not used in bowel or bladder outlet obstruction and not in glaucoma. And the interaction with grapefruit juice may cause toxicity. The mirabegron is a bladder smooth muscle antispasmodic. To be precise, it is a beta-3 adrenergic receptor agonist. It is not used in severe and uncontrolled hypertension, and it may cause tachycardia and urinary tract infections. And last but not least, we have erectile dysfunction. It is the repeated inability to achieve or maintain an erection. It may be due to adverse effects of other medications. And here we have the phosphodiesterase inhibitors. To be precise, the sildenafil, tadalafil and vardenafil. What they do is to inhibit the degradation of the cyclic GMP, because the degradation of the cyclic GMP is the role of the phosphodiesterase. Therefore, if we inhibit the phosphodiesterase, we're going to build up the cyclic GMP, and an excess of it will increase the vasodilator effects of the nitric oxide. Nitric oxide is the reason why these drugs are not meant to be used in recurrent nitrate treatment. They may cause dyspepsia and visual disturbances, and the vardenafil interacts slightly with food, delaying the absorption. Okay, this is it for this video. I hope you understood everything I said. If you didn't, there is a comment section down below. Remember to download this diagram by clicking in the first link in the description. Don't forget to like, subscribe, and share this video to your friends and family if you find this information helpful. Thank you so much for watching, and I will see you in the next one. Ciao! Hope you enjoy it.